So good morning and good afternoon. I think it's a pleasure to present my work in about last 10 years. Okay, so we're talking about the primary hypoparathyroidism, vitamin D binding protein, total and free vitamin D. Okay, so first, yeah, because I think it's a audience is a different background, so I need to introduce the primary hypoparathyroidism. So it's a primary hypoparathyroidism. It's really common endocrine disease. Okay, so the incidence increased by 5 to 10 since 1970s because everybody have to auto measure the calcium level. It's about 200 to 400 per million. For postmenopause women, we have the 1 to 1,000. It's a female dominant. So 80% of the patient is asymptomatic and present at incident finding in Western country. Anyhow, in East, it's not the true. It still have the classic presentation. 80% is single parasite adenoma, and low vitamin D level. We also say the vitamin deficiency is really common in this kind of patient. How we manage this kind of vitamin D deficiency in this patient remained controversial. And let me also introduce the development of this disease. At 60s, not central 60s, a person and Yalo at Mount Sinai in New York City, they developed radioisotope for the PTH. At that time, we have a good tool to diagnose primary hypoparathyroidism. So at that time, it's classic kidney stone, bone pain, and all these things. But since 1970s, so because we developed the methods to measure the calcium, and we find asymptomatic primary hypoparathyroidism. And 87 and 2000, we have a second generation of primary hypo. So we diagnose more of the primary hypoparathyroidism. Also in the 1985, because we screen the woman for osteoporosis, so we find more primary hypoparathyroidism patient. And also 2000, since 2000, we have methods to measure the 25 vitamin D, and we routinely measure 25 vitamin D for the primary hypoparathyroidism patient. So we find a high incidence of vitamin D deficiency, or we say low vitamin D in this kind of patient. And also in 2010, so we also continue measure the kidney stone, asymptomatic kidney stone, and also measure the bone quality in this kind of patient. So as I said before, so the primary hypoparathyroidism, the presentation is different from the developing and a developed country. So also is different from West, from East. So we compare the patient from China and from US. So, and you see, we try to match the age. We try to recruit the same period of time of the patient. And also we try to match the duration. So we found in East, says in China, the patient present more with the severe hypocalcemia and a high PTH and a really low vitamin D. Also in the patient from China also have a high alkaline phosphat and a high incidence of kidney stone and a really high incidence of osteoporosis. While in my hometown, the East Bronx of New Jersey is east of the United States, we find that most of the patient is found by routine annual exam. So we found the high calcium level, mildly aided with the PTH. We also have 50 or 60% have low vitamin D level, and that has really low rate of the kidney stone. Even in kidney stone, most of them is asymptomatic kidney stone is found by the sonogram or the by images. So it's also, so I review a lot of paper from her, the primary hypoparathyroidism from India, Brazil, or even in Russia, it's still have the more symptomatic patient. So we're talking about vitamin D deficiency. Um, Now we see it's really continue also controversy. So we measure the 25 vitamin D in the serum. So most of the society, they say vitamin D deficiency less than 20, we call the deficiency. 20 to 30, we call the insufficiency, and vitamin D more than 30, so we say sufficiency. But you see, now we're talking about vitamin D binding protein. So the D binding protein is the major carrier for the 25 hydroxy vitamin D. So it's circulated in a bloodstream. So 88% of total vitamin D is bounded to circulation. Vitamin D binding protein is synthesized and secreted in the liver as other hormone binding globulin. So in a liver disease, so the D binding protein can be decreased and the total vitamin D will be also decreased. But in some hormone, like estrogen, growth hormone, they induce D binding protein synthesize, and then we find a high total vitamin D level in the body. So also we raise the question, we should the vitamin D binding protein should be considered as a factor to evaluation vitamin D nutrition status. So we also suggest that maybe the vitamin D behave similar like other hormones like testosterone or thyroid hormone. So in that case, so we can see here also vitamin D also just like a testosterone. So the bioavailable vitamin D is free vitamin D and vitamin D loosely binding to the albumin. And you can see we compare the vitamin D binding protein with the thyroid binding globulin. You see the T4, T4 is most T4, like 88 or 90% is binding to the thyroid binding globulin, but also the same is a D binding protein. Most of the vitamin D is binding to the D binding protein, only like less 0.2 or 0.1% is free. Also for the compared with sexual hormone binding globulin, we can see sexual binding globulin binding most of the testosterone, and in female the binding for the estrogen. So when we calculate, actually when clinically we calculate, we evaluate low testosterone level, we should calculate the bioavailable vitamin D. Also clinically we evaluate the thyroid function. Most of them we need to measure the free T4. So we just argue maybe we should the same as the vitamin D binding proteins. So you see for free vitamin D hypothesis is became more popular now, but still it's not in the mainstream. In this concept, that just say only the free vitamin D can permeate through the cell membrane and then combine the vitamin D binding receptor in the nucleus, and then they have the physiology function. But the vitamin D binding protein also have some other functions, so that make the concept a little bit complicated. So we see the vitamin D binding protein also help the 25 vitamin D in kidney and parothyroid tissue to to the tissue and become 125 dehydroxyl vitamin D. So for this, we try to compare the, so we did our study, so we compare the primary hypoparathyroid patient with control. So we measure the vitamin D, we measure the total vitamin D, and we measure the D binding protein, we measure the PTH, calcium, phosphorus, we measure everything. And also we calculate the free and bioavailable vitamin D. Use the formula just like calculate the free on the bioavailable testosterone. It's a formula. This paper is published in 20, more than 20 years ago in JCEM. So we also measure the free vitamin D by the newly developed methods. We also use ELISA assay. So the data express the mean plus standard deviation. We also do the correlation study. And okay, so that's what I just try to present our first publication. So we published our first paper in 2014. At that time, we have 25 patients. We find the patient have, so this is a paper we compare, we have 75 primary hypoparathyroid patient. This kind of patient have a high PTH and high calcium level. You can see we match the age and BMI. So the primary hypo patient have a high calcium and high PTH. So not surprised that this patient, our primary hypo patient, have about 20% low of the total vitamin D level. To our surprise, the D binding protein is also about 20% lower compared to the control group. And also you see the D binding bounded 20 vitamin D also is about 20% lower than the control group. So the albumin bound is a little bit low. So end up, we can see, the free vitamin D is not different between these two groups. So also bioavailable, they are a little bit lower, but not significant difference. So we raise the concept. So this total vitamin D is low, so actually about almost 80% of patients have 25 vitamin D below 30. So we call the vitamin D deficiency or insufficiency, but the free vitamin D level is not different. So to use the as a figure, so we can see that D binding protein is lower in the primary hypo patient. The total vitamin D is lower. You see the total vitamin D is lower, but the D binding protein is lower also. But the calculated free vitamin D actually is not different between the two groups. And the bioavailable is also not low in this patient. Okay, so we just say this low vitamin D in primary hypoparathyroid patient is vitamin D deficiency or just a low vitamin D. And we also have 25 patients. We did a surgery. So 3 months after the surgery, we found more than 3 months after surgery, the D binding protein actually returned to normal compared with the control, and also the 25 vitamin D level is also up a little bit, and the free and the total free and bioavailable also increase after surgery. And we don't show the data, but we found the vitamin D binding protein is correlated, it's negative correlated with PTH levels. So, and then, so we, in next one, we also publish a paper, we measure the free vitamin D. So because the people argue, you calculated the free and the bioavailable vitamin D, but it's really it is rare when you measure vitamin D by free directly. So we have 40 patients. We also match age and BMI. So so we also find the same. We confirmed our previous study. We show the primary hypoparathyroid patient have a low vitamin D binding protein, low albumin level, and most of the patient have vitamin D insufficiency or deficiency compared the control group. But you see the calculated bioavailable vitamin D and the free vitamin D the same. Also, we measure the free vitamin D by a new methodology in our lab. We found so the free vitamin D is no different. Again, we raise the question, this low vitamin D is really vitamin D deficiency or low vitamin D level. So in take home message for our first part of a study is we just summarize. So primary hypoparathyroid patient, they have a low total vitamin D and a D binding protein compared to control. But while the most of the patient, the primary hypo patient have a low total vitamin D, and we call so-called vitamin D deficiency, while the calculated or measured free vitamin D remain relatively stable. So that's the first concept. Another concept is the so the definitely because low vitamin D, they combine less circulated vitamin 25 vitamin D. So the low D binding protein is contribute to the low total vitamin D level in this kind of patient. So because after surgery with the PTH increase and D binding protein back to normal, also we find the correlation between PTH and the D binding protein. We suggest the PTH might inhibit D binding protein synthesized through the PTH receptor in the liver. We also suggest clinically, well, patient, we should be cautious to treat the low vitamin D or vitamin D deficiency in this kind of patient, since the free vitamin D is remain relatively stable, and we have more data to show that. And later on, we're talking about another concept. Another concept is about 20 years ago, a group in Columbia group, so they developed a concept we call the normal calcemia hypoparathyroidism. In doing that, you should have a consistent normal calcium level, but the PTH level is elevated, and rule out any other secondary cause of the raised PTH. So we've tried to screen our patient in about 1,000 sample. We found 10 primary normal calcemia primary hypoparathyroid patient, and we have a 20 age and sex the BMI matched group. So we measure the total vitamin D, PTH, and also we measure the new the free vitamin D, and in our the free vitamin D level in our normal range is about 5.5 plus 2 picomolar per. So that's our cell here. As we see here, I know that, and so we compare the normal normal calcemia hypoparo with the control. And so we matched both group by age, BMI, actually by serum calcium and albumin. And the only different, and also we match the only different is the PTH in this group of patients is much higher than that. But to our surprise, but this patient, because the total vitamin D is more than 30, so they suggest the patient has a vitamin D sufficiency. But to our data show is in this kind of patient, we measure the free vitamin D is about 20% lower than the control. So so that's a figure we can show here. Even the total vitamin D is the same compared to control, but the free vitamin D is about 20% lower in this we call it in normal calcemia hypoparo. And also we did correlation study, and the total vitamin D in this group of patients, they don't have any correlation with the PTH level, but we find a really nice correlation between the free vitamin D and the PTH level. So that's our another study. So we suggest in our conclusion for this paper, we suggest the total vitamin D is normal, but the free vitamin D is low. So one possibility of this is this normal calcemia hypoparo patient, they may have a higher D binding protein level, and we are still in our process. We're trying to recruit more patients, and we measure D binding protein for this group of patients. We just say, the woman take the estrogen contained oral contraceptive, they have a high D binding protein. They also have the high total vitamin D level, but the free vitamin D is no change. As we also say, and end stage liver disease, they have a low D binding protein and no DBP. They also have but total vitamin D is low, but the free vitamin D is normal or even higher. Another possibility is the vitamin D binding protein, the genotype may be different. So all of us know the African American that have a low total vitamin D level than the Caucasian subject. But the free vitamin D is the same, or even the D binding protein by a polyclonal antibody is normal. So, but importantly, we suggest the total vitamin D level in a normal calcemia hypoparo may be not good indicator for vitamin D status in this kind of patient. And we suggest at least part of the normal calcemia hypoparo is not a primary hypoparo, maybe the second hypoparo due to vitamin D deficiency or insufficiency. And we also expand our study to the other groups. So I can summarize our review paper and the other study. So this table is continue expanding. So nephrotic syndrome and end-stage liver disease and critical ill patient. Critical ill is ICU patient. If you measure patient in ICU, cirrhosis patient, they have total vitamin D level are low, and also, but the D binding protein is also low. The free vitamin D level is normal or even higher in this patient. Just most recent paper published by a group, they found that the free vitamin D all unbounded vitamin D is no change in a critical ill patient. And I just tell you, in a COVID patient really sick, they also have a low total vitamin D level, and the D binding protein may be also low. So that's our other job to do it. So, and menopause women, because estrogens were low, so they also have a low D binding protein. The total vitamin D level may be also low, but the free vitamin D may not change. But on the other hand, the microacromegaly patient take the oral estrogen contained oral contraceptive, or psychosis patient, and they may have normal total vitamin D, but the D binding protein is high. The end of the free vitamin D level is low, you know. So so we just try to introduce a concept for the D binding protein, and the free vitamin D should be considered in certain situation. Take home message for the endocrinologist practice in clinical medicine. We just trying to say it's really complex relationship between calcium, PTH, vitamin D total, and free vitamin D, you know. So PTH and other hormone may regulate D-binding protein synthesized in the liver. Like a PTH may inhibit it, but the estrogen growth hormone may upregulate the D-binding protein. Steroids and other things we still don't know. The insulin effect we don't know yet. So we just say when you evaluate or treat the patient with a mildly low D binding 25 vitamin D level, in this kind of patient, you should consider at least the concept of the free vitamin D hypothesis. But I know most of the lab in a hospital or most university, we don't have we cannot assay for D binding protein or free vitamin D. So in that situation, you may need to consider clinical presentation, PTH, and calcium as a whole. So we also suggest in clinical practice, you should be cautious to treat the low vitamin D level in a primary hypoparathyroid patient, especially the patient have really low vitamin D but a high calcium. If you treat the treat with the low vitamin D with vitamin D, they may increase the chance of hypocalcemia, also increase kidney stone. So we want thanks for the professors for collaboration, and our professor department chair for support, and also we have Dr. Wei San is MD PhD. He developed all the assays, and we have 5 master student and finish the paper and publish a paper. They get the master degree. Now we have PhD candidates in our lab. We also have several candidates, several postdoc, MD, PhD postdoc, and last one is Dr. May. She just back to China. Okay. Okay, thank you, and ready for a few